Good day. Today I will be talking about just one MCQ. An image was given in your NEET Recall and asked what is the image likely to be. And it was infantile hypertrophic pyloric stenosis, and there are a whole lot of other options. Now, unless you know what image will fit in for a diurnal atresia, what image for a malrotation of the gut, you will not be able to tell exactly that this image belonged to an infantile hypertrophic pyloric stenosis. Previously, it was called congenital hypertrophic pyloric stenosis. So let's move. We are not going to talk about this image. We will talk a little bit about hypertrophic pyloric stenosis. Then I'll take you through the images. Now, don't run into the columns. Hypertrophic is 2 to 8 weeks. Diurnal atresia at birth itself. Malrotation can occur to birth, but not necessarily. Intersusception 5 to 6 months. So you see there is a difference in the presentation of time. Next will be nature of vomiters. You know that this is non-bilious. Coming to clinical, there will be a olive-shaped mass in the right hypochondrium and you will get visible gastric peristalsis. In diurnal atresia, you can still get a visible gastric peristalsis. But in malrotation, maximum you might find visible intestine peristalsis or plain distension. In an intersusception, your clinical finding will be a sausage-shaped mass very close to the umbilical or in the right iliac fossa. Our idea of interest today was in the imaging part, that too in the ultrasound. So X-ray will show a dilated stomach, it will show a double bubble, there will be distended bowel loops and again distended bowel loops. But look at your ultrasound. In the imaging, ultrasound has got specific features. Have a look at imaging. Longitudinal section will show elongated pylorus and muscle hypertrophy. I'll take you into the diagram. A double bubble sign even in the ultrasound, a whirlpool sign or a target sign. This is all on your. The same slide I put again to tell you that they might just show the imaging to you and ask you this clinical part. Once you're able to identify, they might trick you into asking the clinical part, or they may give you the clinical part in the stem for you to narrow down on the slide. As you can see, there is enough clinical material that can be given in the stem for you to help you identify that image. Both ways it can work. So it augurs well that when you look at an imaging, go backwards, flashback into the clinical findings. Or if you have clinical findings, fast forward into the imaging findings. Always this correlation should be there, because I have seen by and large, if it's an X-ray, it's okay. But if it's a CT or one of the other imagings, they invariably give you some clues in the stem itself. And those clues belong to the pre-emerging clues. So it presents at 2 to 8 weeks. It is non-bilious because it is in the pylorus. It is proximal to the duodenal ampulla. But others will be bilious vomiting. It can be diagnosed clinically itself. During a test feed, there is visible gastric peristalsis passing from left to right across the abdomen. And in a relaxed baby, the pyloric tumor is palpable as an olive in the right upper quadrant. Now have a look. You can see a bulge appeared here. This is your VGP actually. This photograph is from the pediatric surgeon, Dr. Krishna Kumar. So this is not the olive. This is the VGP. This is the VGP starting off. And it will move here. Your olive may not be easily seen, but you can actually see it here, but you can feel it better. So keep this in mind. Your olive will be in the right hypochondrium and your VGP will start off in the left hypochondrium, cross to the midline and go to the right, which is a dynamic finding. Now, how this can be confirmed? By doing an ultrasound. So this is from Sarah. She's from Saudi Arabia. She had sent me these pictures on LinkedIn. How exactly would you find out that this is a pyloric stenosis? Let's have a look. This is a longitudinal view. See. And this is the lumen, which is terribly compromised. See, small lumen. Not only that, the muscle is all nicely hypertrophied, about 4 millimeter in size on the ultrasound. Now, she has also used a Doppler to find out that there is lot of vascularity in the muscle. Of course, the muscle is hypertrophied. It is likely to have patches of vascularity. This is again from Dr. Krishna Kumar. You can find out this is the hypertrophied muscle and with a very small lumen inside. Okay. Now, it can be readily treated by surgery. But then you have to prepare the patient. The child has vomited. You need to correct the electrolyte imbalance and the fluid imbalance. Not only that, you must drain the contents of the stomach. Number one, it will collapse the stomach and stomach will regain function very fast after the surgery. Number two, you'll know exactly how much of fluid is stagnating in the stomach so that you'll be able to replace. That is a third space fluid loss. It is not taking part in the fluid exchange in the body. It's just remaining in the stomach. So you'll be able to replace the fluid also very well. We talked about the preoperative preparation that is equally important to the surgery. What is known as a Ramstead spironectomy. It can be performed both laparoscopically and open. So you do a laparotomy. This is your thickened wall. You make an incision on the thickened muscle itself till you find the mucosa. So what will happen? The lumen which was compromised is not compromised anymore. Mucosa will be there. So the lumen is not compromised anymore. The serosal incision is made. I'll show it to you here. You will make a serosal incision like this. It's already open, so I'm not showing. You'll make a serosal incision. Keep on opening the layers unless you find the mucosa and stop at the mucosal level. The mucosa will bulge out into the wound. That is your end point. Now, you must also know where is the end point here. Distally, you must know the end point. Because if you didn't open up the hypertrophic segment, you will still have a problem. So, what can happen? This mucosa, for some reason, it can perforate. Your knife may be too deep enough and make a nick on the mucosa and it can perforate. That's a complication. Now, let's have a look how the intra-op specimen will look like. So this is your pylorus. Somebody is holding it between the thumb and the index finger. They kept on making an incision here repeatedly. Finally, the mucosa is bulging out. You can see that the mucosa is bulging out into the wound. Now, this is your thickened muscle fibers. See, very thickened muscle fibers. Now they can no longer obstruct the lumen. This is a laparoscopic pyloromyotomy sent by my junior colleague, Dr. Krishna Kumar. Now, when they see through the laparoscope, same thing. You can feel it in your open. In a laparoscope, you can see that olive-shaped swelling. This is the pylorus. Look at the difference. It is standing out like that. This is rest of the stomach. A knife is introduced and made an incision over the hypertrophic part. The incision is deepened unless you start seeing the mucosa slightly. It's not the mucosa, it's still the muscle. Finally, if you see, you will use an instrument and just tease the muscle away from each other till the mucosa will bulge. You can see the instrument getting in and trying to prise the muscle layers away from each other. This is like, if I can explain further, this is like putting a blunt instrument in this gap and prising it open. Now, post-operatively, you can see how it has got prised open and you can see the mucosa bulging. So, you have a instrument you have introduced between the muscle layers and you are just opening the jaws and you can see the mucosa just bulging into the wound. Post-operatively, you need to give IV fluids for 24 hours, then you can start feeding. The baby may have small occasional amounts of vomit, which you probably can observe. Surgical complications, if by some chance this mucosa gets perforated or punctured, then it is a problem. But usually what happens, even that small perforation will heal by itself, provided you keep the baby nil only. And pyloromyotomy has no significant long-term sequelae. So let's look at the summary. Mostly affects boys 2 to 8 weeks. Projectile vomiting after food, and it is non-bilious. You can use an ultrasound to confirm. This is your clinical finding, a gastric peristalsis and an olive. And what is the electrolyte imbalance? Hypochloremic metabolic alkalosis, and that has to be corrected. In fact, I have made a presentation on complications of gastric outlet obstruction in the adults. It's the same thing in children. Only thing is their physiological reserve is really bad. So if you go to that particular presentation, you will find out the metabolic changes in prolonged vomiting. And finally, the surgery is your pyloromyotomy, which can be even open surgery or through the laparoscope. Now, coming to its infantile hypertrophic pyloric stenosis, any vomiting in infancy divide into bile-stained and non-bilious. Now, again, bile-stain you divide into neonate and older infant. When it comes to non-bilious, the first thing that should come to your mind is hypertrophic pyloric stenosis or a gastroesophageal reflux. Then you can have non-specific symptoms of a serious illness like your infection, meningitis, gastroenteritis, a whole lot of things. The only thing is, in all these issues, patients will have non-bilious vomiting, but the child will not be hungry. That is the only way you can look at the various DDs here, how you can eliminate the whole lot out. So, as I told you, X-ray and ultrasound we had seen. Now, let's look at what each particular diagnosis, what type of ultrasound it will have. Now, don't run into the images. Please do stay with me to understand. So, you have this hypertrophic pyloric stenosis. In clinical history itself, you will get enough clues. They might say male, 2 to 8 weeks, non-bilious vomiting, and olive-shaped swelling. Then you know, even without looking at the imaging, that hypertrophic pyloric stenosis, but still you go and see the image. What you will find in the image, one, you will get an elongated pylorus. And number two, you will get a hypertrophied muscle. Fine, anything white will be muscle on ultrasound. What about diurnal atresia? You see there is an atretic segment there. Now this atresia may not be complete. If it is not complete, then air will be in the stomach, some amount of air will go into the duodenum. you can have a double bubble sign. What about malrotation? The whole small intestine and part of the large intestine has got rotated. So naturally the vein and the artery also will be rotated on itself. It is not going to come beautifully like in your normal. It's not going to come like this from the aorta. Your artery and vein is not going to come like this in your aorta. Your artery and vein are likely to be twisted also. This is known as the whirlpool sign. See. Now you can make out this is the vein and this is the artery. In the CT, after giving contrast, with certain seconds they note the arterial phase and another seconds they note the venous phase. That's how they make out, and they are able to, both will have contrast, but they'll be able to tell this is the vein and this is the artery. They are curled on themselves. This is called as a whirlpool sign. Now coming to intersusception, you know it's the ileum which goes into through the IC valve, it goes off into the cecum. Reasons are many. In a child it is enlargement of the Peyer's patches and it happens at 5 months. So clinical history will give a clue, saying child at 5 months or 6 months passing red currant jelly stool and there is a sausage shaped mass. The whole thing will look like a sausage shaped mass, will feel like a sausage shaped mass in the right ilia fossa or in the umbilicus. So clinical history will give a clue, and there is something known as a target sign. Let's have a look. There is something known as a target sign. See, very clear cut concentric. That means one bowel is gone into the other bowel. It is as simple as that. It is like taking a cross section here and looking at the ultrasound end on. So you must know how the images will look for these various diagnoses. Now, if you have a doubt between intersusception, which is target sign, and whirlpool sign, then try and look for clues. Clues will definitely be there in the stem. Or if you look, this will be just like a hazy whirlpool. It won't be clear-cut definitions there, whereas a target sign will have clear-cut definitions on an ultrasound. Now, why I purposely put these, because these were given in the stem and you must know how the image will look for the various options given in the stem. So thank you again. Now, whenever we discuss the MCQs, since the examination testing agencies don't release the questions and the options and the correct options, like unlike other exams, very difficult for us to be exactly predicting what exactly were the options, what exactly was the stem. So we depend on the students to give us the feedback. So basically, if you look at it, we are just discussing the themes. So you must understand that the same question is not going to come next year, but the theme is likely to be repeated again and again. That is why when I discuss the question, I also try to bring in n number of MCQs that could be framed across this theme. Thank you very much, and please do subscribe and share, and also my Telegram channel. You want any particular questions to be dissected, to be analyzed, please do post on my YouTube channel.